Tamil knowledge. Vanakkam.
Yeah, no.
So my role is I'm a consultant neurogeriatrician, so I deal with stroke, Parkinson's, and so the history of Parkinson's. I don't know if you guys know how long you've kind of known about it and what's been done so far, and why, what, when, and who are affected, the drug therapies that are currently available, and the management of the 4 stages of Parkinson's. So I want to just touch on these aspects, and then you can ask questions after we finish. So James Parkinson described Parkinson's as we know it in 1870. So that was when he first wrote 10 patients he observed and wrote an essay on it. And that was later termed as Parkinson's disease by another neurologist called Charcot. That was 40 years later. So it's been known for a while, but not many people understand what happens with it. And in 1938 was the first time they figured out that it was to do with the basal ganglia in the brain. That's the part of the brain that is affected in Parkinson's. And levodopa, that syndopa that you guys use at the moment, 1957. That is when they tested that in animals. So it's not been in the market for that long. So Kotzias tried it on human beings in 1967. So it's been in use since then. And then people discovered that basal ganglia, there were Lewy bodies, which was the basic pathology in Parkinson's disease. So what's Parkinson's disease? It's a progressive condition, and it's a chronic condition. It's not a sudden thing that comes on and then stays like that. And it is to do with the dopamine neurons in the substantia nigra. That's the part of the brain, but that's one part of it. And you need about 80 to 90% of the neurons to have gone by the time you present with the symptoms. So you might have had Parkinson's for a while, but until you get to the stage where 80 to 90% of the cells are dead, you don't notice the symptoms. However, these Lewy bodies are not specific only to Parkinson's. They're also seen in conditions like dementia, Lewy body dementia. So we don't still understand the entire pathology or how Parkinson's is caused. So the causative mechanism, there are a lot of postulations, but nobody has a definite answer to it. So the key thing is about the dopamine chemical. So the dopamine is the chemical which suppresses some of the neurons which are responsible for the shakes. And also it balances the stiffness in the muscles. So those are the two key functions of the dopamine. So the problem when you don't have dopamine is you notice the shakes, you notice the stiffness and the slowness of movement. So these are the key things that the dopamine helps with. And it modulates, or there are different pathways in the brain. The nerves kind of connect with millions of neurons. So there are other chemicals that can be given which mimic dopamine or kind of act like dopamine. So that's why some of you might be on dopamine agonists and things. We'll touch upon that. Now, what are the other chemicals that are lost in Parkinson's? So it's not just dopamine, as I said. So serotonin, noradrenaline are the other chemicals that are also lost, but it's very hard to replace them. And we don't know how exactly what they do and things like that. So that's the reason why we are not using those. So I'll come to some of the symptoms in Parkinson's which are not related to dopamine and then explain a little bit more. So I don't think you can see it, but that's the pathology in the brain that we see post-mortem. How do we see when a patient is alive that they have Parkinson's? We now have scans which pick up the amount of dopamine that's present in the brain, called a SPECT study, or a dopamine transporter scan called a DAT scan. So those scans can be used when the diagnosis is not very clear. So some people might not respond to the levodopa medications, and there is ambiguity whether it's Parkinson's or not, because there are a lot of tremors, shakes, which might not be Parkinson's. So there's the dystonic tremor, essential tremor, other things that can cause shakes, but they're not Parkinson's. So how do we differentiate between one and the other? The normal scans can't tell that. The MRI and the CT scan don't differentiate between the two, but it's available in India also. You can ask for a SPECT scan, which is a dopamine transporter scan, which looks at the dopamine levels in the brain. And it also gives a clue as to how much of the cells are lost. So you can see whether they're far down the line or in the early stages of Parkinson's. So there are various uses to it. So this slide just shows how the progression, if you look at people clinically and do the scan, you can actually correlate that with the amount of dopamine in the brain. So this orange dot is where the dopamine is in this, which goes down as the disease progresses. And these are the different pathways in the brain where the dopamine, serotonin, and noradrenaline that I was talking about impact on the Parkinson's symptoms. So what are the symptoms of Parkinson's? So most of you are aware of the stiffness, slowness of movement, the tremor, the small handwriting, the problems with walking. And then in the later stages, you have the dyskinesias, which is the fluctuations related thing where you have involuntary movements. So sitting in the room, people start fidgeting and moving around. It's not under their control. And the fluctuations, meaning the medications sometimes work and sometimes they don't work. So it's very key for you to understand what an off period is and what an on period is, because that is where the thing is. So if you look at diabetes, a lot of people understand what a hypo is. So similarly in Parkinson's, we have something called off period, which so the off periods are what we refer to as hypo in Parkinson's. So there is less of the dopamine. So the fluctuations, that's the key thing for you to mention to the doctor you see, because that makes a key difference in what medications are given, how they're adjusted. So I will touch upon that a bit more. So what other symptoms of Parkinson's can you think about or expect? So they're related to the digestive system, the gastrointestinal system, to the urinary system, which is the bladder. So you might have a lot of problems with nighttime going to the toilet too often, sleep problems in Parkinson's, pain issues. It's been well recognized now. So not related to arthritis. So we're calling it as lower limb pain or shoulder pains or back pain, which is related to the medication. So when you have an off period, you have more of the pain. So we have now scientifically shown that the pain threshold is reduced when you have low dopamine. So there are various SPECT images to prove that. Memory problems, that is again related to Parkinson's disease. Fatigue, not physical fatigue, not because you've been doing a lot and you feel fatigue, but we're talking about central fatigue. Apathy, which is where you don't feel like doing anything. It is not the same as depression. There is a difference between the two. Depression is also a part of Parkinson's disease. Then you can have weight change, excessive sweating, sexual problems. So a whole lot of problems related to Parkinson's, which a lot of people don't really know that it is due to Parkinson's, and they don't tell the neurologist when they go to see them about these problems. So I want to highlight on those. The typical criteria for Parkinson's diagnosis is based on the motor symptoms. The motor symptoms are referred to as the slowness of movement, the stiffness, and the tremor. So these are the only things which people can see that make the diagnosis, but there are a whole host of other symptoms which, unless the patient or the neurologist asks about it, are not identified with Parkinson's. And usually the onset of Parkinson's is also a clue. If you have tremor in both sides at the same time, it's unlikely to be Parkinson's. So usually it starts on one side and spreads to the other, and it is a progressive condition, so it gradually gets worse. And the typical Parkinson's patients you see have a stoop posture and a very shuffling or a Festinian gait, we call it, very short steps. So that's again a very common sign. Now, in this we have different types of Parkinson's, in the sense some have tremor dominant Parkinson's, some don't have a tremor. So you don't have to necessarily have a tremor to have Parkinson's disease. And then you have mixed type, where you have a combination of the tremor and non-tremor. Sometimes they have the tremor, sometimes they don't. So additional things to look for in general would be the facial expressions are reduced, the blink rate is reduced, so the blinking speed goes down. The speech becomes very monotonous, so there is no up and down in the voice, and there is a very low volume speech. These are kind of things to notice. And the dexterity of the hand, so the skill that you can button and unbutton things and things like that. These are the early things to pick up on. And a lot of people present orthopedic surgeons with frozen shoulder or a stiff joint and things like that. Often it's not recognized by the orthopedic surgeons. This comes out much later, but they might have had Parkinson's since then. Smell issues, that has been identified for some time now. Some patients have it, some don't have it, and now they understand why some don't and some have. Swallowing problems and dribbling of saliva, that's a very common problem. As the disease progresses, you see a lot of people having issues with swallowing and drooling of saliva. So what I refer to as the non-motor symptoms are not related to the tremor, stiffness, and slowness. It's the other ones like sleep, anxiety, depression, Parkinson's-induced psychosis. So the hallucinations and paranoia, all these are related to non-motor symptoms. Depression, constipation, pain, all these are the non-motor symptoms that we routinely screen for. So for that, there's a very simple tool we use in the clinic called a non-motor questionnaire. It's a 30-item questions which has a simple yes or no mark to it. So it's a very simple thing that you can also download from the internet. It's free. And if you were to look through the questionnaire, I have it. You can't see it, but I'll give you the slides to Sudha so she can put it up on your website and you can see what I'm talking about. So when you go to the neurologist, then you can identify which symptoms you have, and then they can try and address those. So that's why it's quite useful, because for the neurologist to spend so much time asking these questions, they might not have amount of time with you. And I realize in India that it's much harder than in the UK. We have about 30 minutes to 40 minutes with a new patient, and about 15 to 20 minutes with a follow-up patient. But I believe that that's not the case in India. You probably see the neurologist for 3 to 5 minutes. So for you to highlight these issues, it's quite useful to have this questionnaire that you can see these are the symptoms we have, and then tell them that we have these, can you address these issues? Then you might be saving some consultation time for the neurologist. I don't know if they'll like me for it or not, but that might be a way forward. So causes of Parkinson's are unknown in most of the cases, but there are some genetic forms of Parkinson's, especially in the younger onset Parkinson's. And we have identified about 13 mutations so far, but most of them are autosomal recessive, meaning they're very unlikely to pass on. But autosomal dominant inheritance, they're found in two countries, one in Italy and one in Greece, so it's very rare. So juvenile Parkinson's, we call it, or young onset Parkinson's, that's the usual genetic link to it. Now, a lot of people blame it on environment, but nobody's kind of found anything that implicates it. So some people think it's probably a genetic susceptibility with the environmental triggers that causes Parkinson's. So still people don't understand what actually causes Parkinson's. Risk factors wise, for sure, is old age. So as we all get older, we are at risk of getting Parkinson's. So nobody is exempt from it. Highly likely, if you have identical twin who has Parkinson's, you're likely to get it. Probable is if you have a positive family history, you probably can get. And possible link is with pesticides, heavy metals, like people in the welding industry with manganese and things like that. And industrial pollutants and things like that. And groundwater without being filtered, which has higher lead levels and things like that. So these have possible risk factors. Repeated head trauma, like for example, Muhammad Ali, they think that that's possibly the cause for his. Now, don't go and do this because I said this, but possible protective effect is smoking. We don't know why. Now, Parkinson's, why is this now being in the limelight is because we have an aging population, and as I said, the highest risk is old age. And the diagnosis is being made better now compared to before, so that's one of the reasons why I think there's more of a prevalence compared to before. And it will be
one of the most common neurodegenerative disease in the world, and the figure is supposed to be doubling very soon. So there'll be about 13.9 billion is the cost of what it costs for in Europe alone for Parkinson's patients. So that's the um, health monetary side of things. So it's a huge financial burden on most countries at this point in the Europe, but in India, again, that burden is borne by the patient, so it's going to be a huge issue. So what treatments are there for Parkinson's? So levodopa, as we mentioned earlier, 1967 was when it was first used. So it's been one of the oldest drugs that we know that's being used. And then the dopamine agonists. So ropinirole, Ropac that you have, pramipexole, and the rotigotine skin patch. I'm not sure if any of you are on it, which is quite a good one to use. And apomorphine infusion or the Penjects, which are being launched in India, I believe. So these are in the dopamine agonist categories. Then you have something called COMT inhibitors, which is the entacapone or Stelivo or things like that that most of you might be using. This basically is not a dopaminergic drug, but it prolongs the effect of the dopamine when it's taken with it. So that's why you're advised to take it only when you take the dopamine. So you take it with the syndopa. And then you have rasagiline, which is a MAO-B inhibitor, which again prevents the breakdown of the levodopa in the brain. So that's how these two are added on to your syndopa. Now, I've noticed that a lot of patients are on an anticholinergic drug called benzexol. I think here it's called Pacitane. So it's a very old school thought. So how this drug works is, so it's not a dopaminergic drug. So it's blocking the acetylcholine, which is what dopamine is supposed to be inhibiting. But the problem with that is it has more side effects. Because as it is in Parkinson's, you have less acetylcholine, which causes memory problems. So it causes more of the confusion, hallucination, and urinary problems in Parkinson's. So we don't tend to use it much in the UK. But once you've been on it, it's very hard to take you down and stop it. Because it has a mood-enhancing effect, which is very addictive. And then you have amantadine, which helps with the dyskinesias, which is actually an antiviral drug, which they found has some anti-Parkinsonian effects. So most of the treatments that you see for Parkinson's, they're not for cure. Therefore, controlling the symptoms of Parkinson's. So just like diabetes, you're trying to boost the levels of insulin, we are trying to boost the levels of dopamine in the brain, which is reduced. Now, what are the problems with levodopa? Over 5 to 10 years, what you see is the problems with dyskinesias and fluctuations. So the fluctuations are the key issue there. When I say motor fluctuations, so the off periods and the peak dose dyskinesias are what I'm referring to. And how levodopa preparations make an impact, again you have 125 milligram preparations, 250 milligram preparations. Some claim that they're longer acting, so they take it at night. And then you have the Stelivo, which is the combination of the entacapone with syndopa. So people have tried various things to smoothen out the ups and downs in the delivery of levodopa. So what happens is when you take levodopa, it has to go through your stomach, get into the intestine, and then get absorbed. But the problem with Parkinson's patients is we know that there is already a problem with gut motility. So the stomach doesn't empty as quickly as in normal patients. There is a slowing of the movement of the contents of the stomach in Parkinson's patients. And that has a delayed on effect, we call it, where the medications get absorbed much later after you take the medications. So what most people think of doing is at that point they pop another pill. What happens is then it builds up. So 2 pills go in at the same time almost and causes a very huge surge in the dopamine levels. And that triggers the dyskinesias, the involuntary movements, and the dystonia. Dystonia is painful spasms in the muscles. So the muscles can go to a specific posture. So your hand might go like that, or your leg might go like that. So this is what we call as dystonia. And that's induced by either having too much of dopamine or too little of dopamine. So the graph goes up and down like this. So what we need to try and do is get the levodopa stimulation to be in an even keel. So on a continuous level rather than down. To mimic how the brain is normally having dopamine. It doesn't go up and down so much in a normal patient. And there are a lot of people who are worried about taking levodopa because they think it's toxic to the cells, it makes the condition worse. But it's not the levodopa itself, it's the condition which is getting worse by itself. But the ups and downs cause the plasticity, we call it, of the neurons to go haywire. So that is where the problem is. It doesn't directly cause the toxicity, but it is about how it's delivered. So if you have a more smoother or continuous stimulation, you don't have so much of the side effects. And there are a few studies to prove that. We have an L-DOPA study where they gave very high doses to patients and they found that the side effects were much higher. If you take it too frequently, the side effects are too much. So that's why we recommend it's taken at least 4 hours apart. But a lot of patients over time might need it every 2 hours. So it's not a thing that is set in stone. So we now believe that a continuous infusion is safer than a pulse style therapy. That's where the advanced therapies come in. And what are these advanced therapies? We're talking about apomorphine infusion, deep brain stimulation, and levodopa. I'll touch upon those as well. Now, complications of levodopa is the dose failure because of the poor absorption from the stomach. Then you have dystonia or super offs because of that. Now, early morning off periods are another issue because you've not taken anything in the night time. You can't just wake up in the middle of the night to pop a pill and go back to sleep. So when you get up in the morning, your muscles might be very stiff and you're not able to move, and you have to take the tablet and wait for maybe 45 minutes or an hour before you get moving. So that's the key part of your day gone, because that has a knock-on effect on the rest of your day. So these early morning off periods can be more of an issue than people recognize. So people might dismiss saying it's okay, it's only half an hour or an hour that you lose in the morning. But actually it's not true. It has a knock-on effect on everything you do in the later part of the day. So there are treatment strategies to address that. The rotigotine patch that I was mentioning earlier has a better profile in the sense it has a 24-hour stimulation when you apply on the skin, so less incidence of early morning off periods. So the key thing, as I said, is maintaining the levels of levodopa within the range where it's optimal stimulation, not too much, not too little. What is dopamine dysregulation? So this, I don't know how much aware you are that the dopaminergic dopamine agonists, which is the ropinrole, pramipexole, they can cause you to have gambling issues, funding issues where you're hoarding stuff. So these are well known in the West, but I'm not sure if people in India are well aware of this, because they're not aware of it themselves. It's the family that needs to keep an eye on it. A lot of people in the UK have lost thousands of pounds because when it first came out, people weren't aware of it. They bought like 5-6 cars that they didn't need. They bought houses that they didn't need. And the brain doesn't, it's a reward chemical, dopamine. So when you take it, you feel good. And same thing with gambling, you feel good. So it gives you that dopamine rush. So it affects that part of the brain, so thing to be aware of. And taking too much dopamine can also cause hallucinations, psychosis, paranoia. Like I have had few patients complain that the wife has been unfaithful, things like that. So it has a major implication on their social life. We call it impulse control disorders. That's the name for it. Excessive eating at night, chocolate especially, internet use, hobbies. Sometimes hobbies can be good. I have a patient who paints, and he takes these drugs, and he says that his art has taken off into a new level. He's doing better. He's being more creative. So in some patients, it kind of can be for the better. So the dopamine agonists are similar to levodopa in the sense how they work is they stimulate the dopamine receptors directly in the brain, but in that they have three different receptors. So that's where the difference is. We call it D1, D2, and D3. So the D1 receptors are the best, and that's what levodopa stimulates. And apomorphine is the next drug which is as effective as levodopa. In controlling motor symptoms, the D1 stimulation has the best effect. So D2 and D3 are more of an issue because this D3 receptor is the one responsible for reward behavior in the brain. So that's where the impulse control disorders play a part. So that's why dopamine agonists have more of an issue with that. Saying that, even levodopa has a D3 effect. So if you take too much levodopa, you can still have these impulse control behavior. The advantage of taking dopamine agonists is you have longer acting dopamine agonists now. The Ropac XL, what you get, works for 16 hours as opposed to 4 hours, which compares to the levodopa. So that's why if you take that, it's like having the reserve fuel in the tank and taking the levodopa on top. So the fluctuations are less. Now coming to apomorphine, it's injected as a subcutaneous injection, so it bypasses the stomach. So that's the advantage of having the apomorphine, which is being launched in India. For people who have the poor absorption, so the lack of effect from taking tablets, so you have a delayed on response. So you can take the apomorphine penject as a one-off shot, so it kickstarts you straight away. So even the early morning off, so you take the pen, it works in 5 to 10 minutes, and you can start your day, and then the tablets will kick in. So that's the additional option you have by having those apomorphine pens or whatever, so that's being launched. A lot of people have asked me about it, so I thought I'd cover that. But the problem is these pens can also be abused. People get that high, and they use it more and more often, and that leads to psychosis and paranoia, because apomorphine has a tendency to cause more hallucinations and paranoia compared to levodopa. Now the COMT inhibitors and the rasagiline that I explained, they are effective but not so effective. They prolong the effect of levodopa by an hour or two. So as the disease progresses, that also gets harder. So the effect of those doesn't last forever. Now who to opt for deep brain stimulation? So this again, a lot of patients I saw asked me. The selection criteria for DBS is the key. If you do it on someone who is not responding to the levodopa that well, they won't respond very well with deep brain stimulation. Now, tremor is very effectively treated by DBS compared to the tablets. So if somebody is majorly affected by the tremor, then DBS is a very good option. What are the drawbacks of DBS? That's where it all needs to be very carefully thought out, in the sense, gait problems, memory problems, and speech problems can actually get worse following deep brain stimulation. So that is where the problem is. And they're trying to bypass these side effects by doing various things, but we are still in the early stages of that. We have directional leads and sensing leads to bypass the side effects of that. But I believe that's not there in India, and that's more of a research program that we are doing in the UK. And with that, we have noticed that there is reduction in the side effects with swallowing, speech, and gait issues. But in India, you don't have that. So you have to be aware that these are the things that might get worse if you go for DBS surgery. And what is DBS doing? It's two electrodes put in your brain to the subthalamic nucleus, we call it. And it's passing a small amount of current which mimics the dopamine. So you're giving current instead of the chemical dopamine, and it has a continuous effect. So you don't rely on the stomach absorption and those things. All your medications are reduced when you go on to DBS, but you don't come off them completely. Now, I mentioned the 4 stages of Parkinson's. So the first stage is the diagnostic phase. So until you have 80 to 90% of your cells lost, you don't notice the symptoms. Doesn't mean that you had Parkinson's 2 months before that. It's probably that you had Parkinson's a few years before you notice those symptoms. And that's what we call the diagnostic phase. And in that phase, once we establish the diagnosis, we start on treatment with levodopa or dopamine agonists based on the patient profile. And then you have a maintenance phase. So this lasts good 5, 6 years, where the patients are quite stable on these medications. You don't have to do any major adjustments to their medications. You can see the neurologist maybe twice a year or even sometimes once a year because the medications are working quite well. You don't need to do major adjustments. Then you come to the complex phase. That is where you have the fluctuations, the dyskinesias, where the medications don't work so well. So you have a lot of periods where the medications are not working. And then you have the other symptoms that I mentioned, which might be more of an issue than the walking or the movements. So we call this the complex phase, where the titration of medications is quite tricky to do. And that's the stage where the advanced therapies come in and we opt to adjust the medications based on that. And then comes the palliative phase, which I don't know how well that's managed in India, but there are things that can be used to make things more comfortable towards the end of their life. Patients with Parkinson's don't die from Parkinson's disease. They die from complications of Parkinson's disease, which are related to the swallowing. So they get a lot of aspiration pneumonia. So you get pneumonias, which is the cause of death more than the Parkinson's. So how to deal with these issues that we need to address. So the key thing is achieving the acceptance of diagnosis when you make the diagnosis, trying to explain why you have this condition, what to expect, what's the trajectory, how we can support you through the process. So I think this system needs to be robust, and in the UK we have Parkinson's nurses doing it. I hope at some point in India we have some Parkinson's nurses who are available who can support patients through these things in the future. The key thing is we are reducing distress to the patient with the diagnosis, with the symptoms. So key thing is controlling symptoms, not just the motor symptoms, the non-motor symptoms as well, because they are as important as the motor symptoms. The non-motor symptoms that I mentioned can be a big issue for patients: depression, anxiety, memory problems, urinary problems, bowel problems. Unless they're addressed, just treating the motor symptoms won't effectively improve their quality of life. So also improving prognosis. So there's a lot of, I've given you a lot of doom and gloom, but there are some new things that have now shown to reduce the progression of Parkinson's. There's a new drug called nilotinib, which is actually a cancer drug, which has now shown that it can reduce the amount of alpha-synuclein in the brain, which is the protein which causes the cells to die. So there is some hope there. They've looked at nerve growth factors, GDNF, which has finished its phase 2 trial last year, and they're going to go down the phase 3 trial, which again has shown reduction in symptoms since them going on this. So there are some new things that are coming up which are trying to address disease progression. So the key would be in the future to identify patients even before they develop the motor signs. So 80-90% cells are already lost. So if you can catch patients even before that and use these treatments to prevent progression, that would be the idea. So that's why we are working towards pre-motor diagnosis, we call it. So lack of smell, that should be a red flag. REM sleep disorder, we call it, where people have sleepwalking or talk in their sleep. So this is shown to have a pre-motor diagnosis of Parkinson's. Constipation, major depression. So if you screen patients with this and then do a DAT scan, and if we show that there is a reduction, those patients might benefit by these new therapies to prevent progression before they even get motor symptoms. So that is the future. Now, I think I'll stop here because I've waffled on for too long.
Doctor, can you tell a little bit about stem cell therapy or bone marrow infusion?
So stem cell treatment so far has not worked so well for Parkinson's. The problem being you have to specifically make the cells produce dopamine. So in neurons, you have cells which produce dopamine, some produce serotonin, some produce noradrenaline, and they need to be producing these hormones in the exact place that they need to be delivered. So until we improve nanotechnology to the extent where we can regulate this stem cell growth to fit into that part of the brain, we are far from stem cell therapy being an option. So that is why stem cell therapy hasn't really kicked off, and it's still in the trial phases. So there are various people trying to make it work. So initially it showed some progress, but then the effects didn't last. So that's where we are with stem cell therapy. Bone marrow therapy, are you talking about bone marrow transplantation? Because bone marrow therapy is used for leukemia and other things, but not for Parkinson's as I'm aware. It is more, so like for example, the HIV cure and all those things, so they completely take out someone's bone marrow and then replace it with some donor bone marrow. It's for autoimmune conditions. So if we think that autoimmune related Parkinson's, then there might be some role towards it. But otherwise, bone marrow therapy for Parkinson's, I'm not sure what the future is.
Can you cover a little more about the speech impairment you said?
Okay, I think I'll address both questions together because speech, swallowing, drooling, they're all connected. And the key thing for that is actually speech and language therapy. So you need to get your voice, the decibels, to a certain range. So there are some Parkinson's apps on phones, Androids, iPhones and stuff, which give you a measure of how loud your voice is. So you can exercise your voice every day to get it to that desired level. And that helps again with the swallowing because you're exercising those muscles which help with the swallowing in the same time. Now the problem is not just that. Again, drooling happens because you're not swallowing your saliva. So not because you're producing excessive saliva, it's because you're producing saliva which you're not swallowing. So if you, unless you constantly remind yourself to swallow the saliva, it's going to drool. So there are some timing devices like they make a little noise or a click to remind you to swallow. So these kind of aids might help. So speech and language therapists usually might help with that issue, with the swallowing and speech to get better. So unless you constantly do this, medications are not going to help. Medications help to help free up these muscles, but unless you use them, you're not going to get better. Drug-induced Parkinson's, yes. A lot of antipsychotic medications induce Parkinson's, and especially for patients with schizophrenia or psychosis, they use these drugs and it can cause Parkinson's. What people don't know is some medications which you use for nausea and vomiting, so like metoclopramide, cyclizine, all these medications can also cause Parkinson's symptoms. Even medications used for epilepsy, sodium valproate can mimic Parkinson's. So there are a whole host of medications which can mimic Parkinson's. Depends on which one. If anything which blocks dopamine causes Parkinson's. Now, how to differentiate that with Parkinson's? The dopamine scan will help. If you have loss of dopamine, you're on that medication, you will be able to differentiate between the two.
We have Mr. Ravindran asking about again stammering and drooling, and he's also asking, I wake up a lot at night.
Is it because you have to pass urine or is it sleep issue? Because there is a sleep maintenance issue and a sleep, so there are two things. One is difficulty in falling asleep, one is sleep maintenance. The sleep maintenance is more because the muscles are very stiff, you can't turn in bed, and that wakes you up. And for that you need to have a more continuous dopaminergic strategy to help you through the night so that the muscles are not stiff and you'll sleep better. The same applies to excessive urination as well. And one of the other things you can use along with that is fluid management. So not drinking coffee and tea too much and not drinking too much water in the evening. Drink as much water in the morning. So these are the fluid management strategies that will help. No, you can't. It causes withdrawal effects, so weaning off is the best thing, and slowly is the best. Any drug, always wean them slowly. You lost 20 kgs, yeah. Excessive weight loss, yeah. Sorry, can you repeat the last part? The waist size has reduced.
Waist gain is reduced by 45 inches. Maybe 6 inches.
So weight loss and weight gain both are identified in Parkinson's.
Diabetes. Diabetes.
Yeah.
What do you think?
So first thing we recommend patients to do, it can be due to Parkinson's, but you need to also rule out any kind of malignancy in your bowel. So we ask you to see the gastroenterologist to have a colonoscopy done to make sure that there is nothing else causing weight loss, because that's one of the risk factors for weight loss. Yeah. If that's ruled out, then we think it's Parkinson's, and that's why one of the questions that I was telling you about the non-motor symptoms with Parkinson's, weight loss, that's common, because that usually happens if you have dyskinesias, you lose a lot of weight. But in looking at you, you're not dyskinetic, so it's not very clear. So what I would recommend is first see a gastroenterologist about weight loss. Especially if you have any change in bowel habit, you need to get it looked at.
Yes, it's reversed.
Huh?
She's gaining weight.
Because you're eating more or excessive eating? Normal eating, but you're not walking as much, so you're not burning as many calories. So that also will be there. So weight loss, weight gain is usually, you have to rule out how much calories you're getting, how much you're burning. That balance has to be there. If the balance is there that you're eating as much as you're burning and you're losing or gaining weight, then you need to investigate according to that. So thyroid problems, other things can cause weight gain and other things, so you need to explore those aspects. Which one? I said it has side effects. It's only effective in 20 to 30% of the cases, but once you go on to it, it's very difficult to wean off. Especially in the later stages of the condition, it causes more of a problem because the chemical called acetylcholine is blocked, and you need that for your memory. Otherwise, you get hallucinations, sleep issues, all these come up.
So it's really contraindicated.
We don't tend to use it nowadays in the UK. We started phasing that out about 10-15 years ago.
It is very common here, doctor.
Yeah, that's what I realized, but that's the practice, so you need to. I didn't see it while you're sitting here, so I can't comment.
What was the question, doctor?
Putting out his tongue involuntarily.
Tongue. Yeah, yes, doctor. That is one of the symptoms we often
You
see.
can get a tongue tremor, but not and a jaw
Tongue
tremor.
comes out, like tongue comes out. That's not something
It's
to
a
do.
habit, probably, but it's not the medication causing it, as far as I know. Is that because your jaw is dropping and you're opening your mouth and your tongue cuts out, or?
Yes, sir. Neelakanta.
Doctor, even when I don't have cold, I get ear pain as well as this gland. Occasionally it gets formed. That ENT rules out that there is no problem with ear or throat in this department. So I get glands here as well as ear pain, almost piercing pain. Then it disappears. Also I get sleepy at times, either after breakfast or feeling drowsy or feel like sleeping. I don't know why.
Too little dopamine can cause sleepiness. Too much causes restlessness or agitation. So it's that balance. So if you have too little dopamine, then that causes the sleep issues. The ear thing, there is a thing called the eustachian tube which equalizes the pressure between your ear and your throat. The dysfunction of it is very difficult to diagnose. So ENT can look into your ears and everything, but they can't really check on that. So there might be an issue with that. Do you have problems equalizing when you go on a plane or anything like that? That's usually an indication that there is a dysfunction in that. The glands swelling up is usually an inflammation, which means an infection. That again affects the eustachian tube. So it kind of makes.
Is it due to Parkinson?
It's not.
This pain?
Unlikely. That sounds more like an inner tube dysfunction rather than from Parkinson's.
Is exercise your experience in Parkinson's again, and also how vigorous should this exercise be?
Sorry, I didn't touch upon a major aspect of managing Parkinson's. So in our center, we have a multidisciplinary setup. So what I mean by a multidisciplinary setup is when a patient comes to see the neurologist or a geriatrician, they get seen by the speech and language therapist, physiotherapist, and an occupational therapist at the same visit. So we pick up the problems that the patient's having with the gait or modifications at home or the speech and language therapy issues, and they get seen in the same day. There is nothing in India that I've come across which addresses all these things together. Medications are 50% of the job, but the additional support you get with physiotherapy, occupational therapy, and speech and language therapist play a huge part. So dance therapy, voice, the music therapy, all these kind of things help with the neural plasticity that you are referring to. They promote the other aspects of the other pathways to get activated to improve the symptoms. So though the dopamine doesn't work in that sense, the other pathways recruited for these patients. And we've seen there must be a lot of YouTube videos you've watched where patients are struggling to walk, but they're able to play football and cycle and things like that. It's all because of the neural plasticity. So different pathways are working for these particular activities. So I would definitely recommend having dance therapy or speech and language therapy, yoga, tai chi, pilates, whatever it is to help with the core muscle strength, with balance. So these things are not treated by medications, they're treated by therapies which are quite crucial for Parkinson's. And I think Sudha was going to try and see if she can get everyone together in one place to set this up. I have spoken to a neurophysio who's keen to be part of this, but you have a speech and language therapist, I believe.
We are working with the team.
Yeah. So if you have one unified service who can assess a patient together and provide that support, that would be quite useful.
She used to take one medicine called Inderol, beta blocker. Last time when we met, you told it is meant for essential tremors only. But whether it has got any side effects, can she take?
So Inderol is a thing which reduces your heart rate. So it's used for heart patients so that they don't have angina, that kind of thing. It can also cause depression. It can also cause sleep issues. So my recommendation is why take a tablet which might not be doing anything. So if you don't need it, don't take it. But if you think that it is helping with the tremor a little bit, you have to weigh the risk and benefit and use it. I will not say take this or don't take it. It's the option. End of the day, it's the patient who is experiencing the symptoms, so you need to guide them towards therapy. You can only recommend things, but end of the day, you decide what matters most.
Any other questions? Yeah, here.
In managing Parkinson's, what is the role of natural foods and physiotherapy?
Natural
Foods.
Natural. So we recommend a healthy diet. So there's a lot of foods which have high levels of dopamine, like the fava beans, and I think I can't know the name of this, the vegetable which has very high dose of high levels of dopamine. But the problem with this is the absorption of this is limited. So if you just rely on that, it might not be enough. So definitely a lot of patients don't want to take tablets, they're going the natural route and trying to take this in excessive quantities to get the dopamine, but it's not as effective as the chemical formula because the concentration is higher. So fiber helps with constipation and things. So having a healthy balanced meal is a must, whatever you do. Physiotherapy, as I mentioned, helps a lot with your balance and gait and freezing and those side of things. So physiotherapy is something which you have to do every day, which is quite difficult to do. I had a knee injury and I tried to do it, and I know how hard it is to get that rhythm going and doing it every day. But unless you do it every day, the effects don't last. So as soon as you give up, all that is lost in 2 months, 3 months. So the key thing is to try and do it as consistently as possible. So if you can do that, it helps.
Can you delay the onset and prevent? So that's what I was. So there's some hope with the nilotinib study and the nerve factor study, but identifying it early is a problem. That's, in India, it's not diagnosed early enough to begin with. So awareness goes a far way, and then we're talking about neuroprotection.
Fall has been a starting point.
Or even before, we don't know.
Mumbai Neurology Hospital giving an injection
That's
by
the
a UK doctor. How effective can you explain about it?
So that's the apomorphine that I mentioned earlier. Because it's given through a subcutaneous injection, it bypasses the stomach, so the action is more immediate. It works in 5 to 10 minutes.
How effective, how long
If you're responding to levodopa, it's as effective as levodopa. That's all I would say. So, you can put it under the skin and give it as a pump continuously. So that is the other benefit of it.
Cost factor?
A lot more than that. So I've been told that they're launching it at a discounted price of 50,000 rupees per month.
They say it is 28,000 rupees, and the screening charges they are charging. When by the way of screening, they take the eligibility criteria. They just apply for appointment. So based on the screening only, they decide whether the patient is sick.
As I said, if you don't respond to levodopa, you won't benefit from that injection. So that is what the screening thing is. So they need to make sure that you have Parkinson's disease and you are responding to the levodopa treatment. So if you're not either of those, then that treatment won't work. So there are a lot of patients who have been put on it without the right diagnosis, without checking whether they're responding to levodopa or not, and failed. So that's why they're being very cautious, because they're launching it for the first time. They don't want failures. So that's why they're screening quite intensely. But the key thing there is, what are they using it for? So is it for the off periods? Is it for the dyskinesias? What are you going for to have the treatment for? So the delayed on, so the early morning off periods, these are helped by just one injection. It lasts 45 minutes, and then you carry on with your regular tablets. The infusion is for people who are using these rescue therapies more than 4 or 5 times a day. Instead of keep on jabbing yourself 4 or 5 times a day, we recommend you going towards the infusion therapy. So the infusion therapy I wouldn't recommend straight off without having the rescue therapy. The rescue therapy is just taking the injection as a one-off shot when your symptoms are quite bad. Just like in insulin, you take an extra booster dose if your sugars go too high. Similarly, if your symptoms are too bad and the medication is not working, you can take a booster shot. So the infusion will come later when you're taking too much of these rescue preparations. So instead of taking too much of that, you go on with a regular infusion, which lasts continuous infusion we're talking about.
Give some tips to overcome the drowsiness.
So apomorphine can cause drowsiness at a lower dose. Higher dose has an alerting effect. So that's why the titration phase is quite important.
Fortunately or unfortunately, I'm not taking any allopathy medicine at all. For the first 6 months, I was taking allopathy. So just because of the sedative discontent and continuing oil only. Is it because of Parkinson's disease?
So out of curiosity, why are you going with apomorphine when you're not on any dopaminergic therapy?
I'm just asking you. In fact, I had sensor treatment also. I had taken sensor treatment also. Sensor.
Oh, okay.
Last year I had taken, but
TMS. Okay.
Geostar, I'm not aware.
Those are all temporary effects. They don't last, unfortunately.
So any tips to overcome the drowsiness, like your speech therapy you were taking, anything like this?
See, as I said, too little dopamine causes drowsiness. Dopamine at this right amount will keep you in the alert stage. If you take too much, then it causes sleep issues and paranoia, hallucination. So the key is to maintain it in that range, and each patient is different. I can't prescribe one fits all. So you have to have that slow titration of dose and maintenance of that dose, and then make the corrections. I can't just tell you now what treatment will suit you.
You spoke about the use of the cancer.
Nilotinib, yeah. That's still in the very early stages. It's going through the phase 2 trials at the moment. Then they have to launch a phase 3 trial, then commercialize it. So it's a few years down the line.
We got it at almost 1 or 2 years back.
Yeah. So they're running the trials now because that was case report thing. So then you go through phase 2 trials and then phase 3 trials.
Like it will take what, another 2 years, 1 year?
Depends on how effective it is, then they can, FDA can speed it up. So it all depends on how the study results are.
While coming, and she suddenly got dystonia. She could not walk from there. I don't know whether it is due to over dopamine or lower dopamine.
That's why you have to look at the timing of the dose. And
Just half an hour back, she
so you have to keep a diary of it, whether that was because it absorbed quickly or it hasn't absorbed. So half an hour is unlikely that she has too much. It's probably not absorbed. Then it relieved after a while. So that means that it was off dystonia. So the medications have kicked in and now it's relieved. If it was on, then it would still be persistent. So you have to time it with the medication.
Diabetics prone for
I won't say more prone, but we've seen that the fluctuations in the glucose levels has worse prognosis on the progression of the condition due to the neuroinflammatory theory.
So, about the DBS surgery, I want to know, like, you belong to UK, so I hope you have come across many surgeries there.
I have a lot of patients on DBS.
And is it all very successful, and it is being done for old people also?
In our center we have, and you can Google my name and you can look at one of the first publications looking at older adults over 65 use of DBS for controlling Parkinson's symptoms. We did that with a center in Cologne last November, and old age is not a contraindication. If your brain hasn't shrunk, it's about putting the electrodes into the right place. If the brain is shrunk, because there's too much movement of the brain, because the fluid around the brain is too much, it's like a ball floating in the water. So if it is not in a contained tight space, the electrodes don't go into the right place, and complications are huge. That's why they don't recommend DBS in older adults, because the brain volume shrinks as we get older. But it doesn't happen in everyone. So if you have a reasonable brain volume and there is not much of an atrophy, you can do DBS in older adults. So it's not an absolute contraindication. It depends on the surgeon, the technique, and a whole lot of things. I have to put a word of caution in this. I had a few patients in the UK who traveled to China to get titanium implants in their ear, thinking that it will improve Parkinson's. Absolutely no proof. So there's a lot of people who are desperate for a cure, who do things which are not going to work. I would be a bit wary of those things. And even people have gone and got stem cell therapy done in China when there's clearly no benefit so far. So when you're so desperate, people do tend to do things that are not likely to be beneficial, probably might be harmful. Titanium implants in the ear, probably not a harmful thing, but stem cell therapy can be a harmful thing. So I would just say a word of caution. Just because you're desperate doesn't mean you should try out.
What is duodopa and how it is better than, is it better than apomorphine?
Yes and no. So duodopa is levodopa. The syndopa you're taking in a gel formulation which is instilled directly into the jejunum. So you're bypassing the stomach, it's going as a continuous infusion. And levodopa doesn't have as much of a side effect compared to apomorphine. So that's where the benefit is. But it's more expensive. It's not affordable in India as of now. In Europe, it's affordable because it's free. Otherwise, it's a very expensive thing to even think about. Again, it can be used in patients who have cognitive issues, memory problems. Apomorphine you can't. So that there are some key differences in